continue the discussion on the same topic today. So invite my co-moderator, Dr. Poonam Goyal, ma'am. She is a senior consultant at Max Hospital in Indirapuram and senior ART specialist, authored many books. Welcome, Dr. Poonam. She will be co-moderating me. I now request Poonam ma'am to invite the panelists. Ma'am, do you have the...
No, I cannot see your slides, Dr. Jyoti.
Okay.
You have shared?
No, senior member of our fraternity, Dr. Jyoti Bhaskar, a personal favorite, a very senior consultant, principal consultant, obstetrician gynecologist at Apollo Cradle Hospital in Indirapuram. Welcome, ma'am. She is also the past president of DGF East, co-chairperson AOGD Subcommittee of Quality Improvement, secretary of Delhi Chapter of Indian Menopausal Society, executive member NARCHI, member representative RCOG North Zone. Welcome, ma'am. Inviting another dear friend, Dr. Jyoti Malik, who's an IVF specialist, director at Roots IVF, medical superintendent of JJ Institute of Medical Sciences, Bahadurgarh, and vice chairperson, Haryana chapter of ISAR. Welcome, Jyoti. Dr. Seema Sehgal, madam, who has, of course, held the fort for the last 1 year and did all the hard work, along with Dr. Megha Malik. She needs a big round of applause and a very warm welcome, ma'am, and Megha to you too. So from here, I hope we take it forward from both of you, and I welcome each one of you. So beginning with this topic, I'll now share the slides, and me and Dr. Poonam will just take through this practical questions on PCOS itself. Just sharing the slides. I'm starting it, just give me half a second. Okay, the first question, how to diagnose PCOS and counsel the young adolescent girl, 16-year-old who's come with complaints of irregular cycles. Her BMI is 32 and she has acne, she has mild hirsutism also. So how do you manage this young girl in the OPD? Anybody can answer, but though I'd asked this question specifically to whom I can't remember now. I'd sent the questions, I'll have to take it out.
Yes, ma'am.
Dr. Megha Malik. Yeah, Megha, take it up, please.
Yeah. See, we all know that PCOS in adolescent female is very common these days. So, approximate incidence is 9% in Indian adolescent female. And in this case, we can see that she has a BMI of 32, which indicates towards hyperinsulinemia. So, that is the high BMI more than 25 is diagnosed for hyperinsulinemia. Also, she has irregular cycles. So, that means the ovulation is defective. And acne is indicative of the hyperandrogenism. So all the symptoms towards the Rotterdam criteria fulfill towards a PCOS diagnosis. I go towards more of the practical approach than to put her on a list of investigations which are not comfortable for the patients also. But otherwise, just for the purpose of informing the confirmatory diagnosis, we need to do an ultrasound for her to see the ovaries picture, the volume of the ovary. There are 2 to 9 mm follicles, more than 10 in number. The ovarian volume is more than 10 cc. As said, Dr. Sharma also said that the arrangement of the follicles is typical necklace appearance, stroma is increased. So this indicates more towards the PCOS diagnosis. And also other investigations, if we have to do it for the research purposes, especially Dr. B.N. Chakravarti in his book has mentioned, that is LH and FSH ratio, the second LH FSH ratio, which is more than 2. Others are, if for the hyperinsulinemia, we can do the glucose tolerance test. And we should also do thyroid and prolactin levels because they are usually high in PCOS patients, or if they are high, they can also lead to the more symptoms of PCOS patients. So these 2 investigations are also very important in such patients. And also if we have to measure insulin, the levels are more than fasting insulin, more than 25 milli-international units per liter, and fasting insulin and glucose ratio more than 4.5. Usually I don't do in all the patients, especially the young patients. But if we have to do it or for the clinical purpose, for the diagnosis purpose, these are the parameters.
Okay.
And also we have to rule out, like if you have to rule out the other causes of hyperandrogenemia, that is the Cushing syndrome and late onset congenital adrenal hyperplasia, which is done by measuring the cortisol levels and 17-alpha-hydroxyprogesterone. Now, regarding this patient, when we have to counsel, most important is the dietary and the lifestyle management. Her activity level should be increased. She should include herself in some sports or exercise, which ma'am has told already that 30 minutes of exercise per day. At least 5% of the total weight loss improves the symptoms. It leads to better regular cycles, ovulation, and the better improvement in the hirsutism symptoms, acne symptoms, and all the other hyperandrogenic symptoms. And the diet specifically, it should be more of a protein. More than 40% of the diet should be protein. Less than 30% should be of the carbohydrates, and approximately 30% of the fat. So that is the dietary management.
Megha, that's fair enough. In this patient, I have said that irregular cycles, 40 to 60 days, heavy flow, everything was advised. Lifestyle will not be immediate. She's a student and she's bothered. It's psychologically affecting her. Specific to her menstrual history, how would you advise her?
So, so these days, in young patients less than 20, the recommendation of OCPs is not much because they retard the growth. So insulin sensitizing agents in such patients do have very important role, especially when we take the history. If they are the female is a low birth weight, if she was a low birth weight female at birth, or she has a family history of mother with diabetes, or she has precocious puberty history, we have to take all those parameters from her. If such high risk factors were there, then insulin sensitizing agents have very important role.
Yes, this is now from diagnosis of PCO in adolescents is from this Journal of Pediatric 2015, International PCOS Guidelines 2018. It says that in adolescents, irregular menstrual cycles are defined as normal in the first year post-menarche as part of the pubertal transition. More than one in less than 3 years post-menarche, less than 21 or more than 45 days. More than 3 years post-menarche or less than 21 or more than 35 days or less than 8 cycles per year. So they say that minimum a person should have 7 to 8 cycles per year. If it is not happening, then withdrawal can be added by progestogens. 1 year post-menarche, more than 90 days for any one cycle. Primary and the slide which says how to define menstrual irregularities amongst adolescents. Irregular menstrual cycles are defined as normal in the first year post-menarche as part of the pubertal transition. It takes a little while to settle down the regularity of the thing. The mechanism takes about a year. So more than 1 to less than 3 years post-menarche, less than 21 or more than 45 days cycle. More than 3 years post-menarche, it is less than 21 days or more than 35 days, or at least less than 8 cycles per year. 1 year post-menarche, more than 90 days for any one cycle. Primary amenorrhea by age 15 or more than 3 years post-menarche. This is how the irregularity should be defined in this adolescent age group. For adolescents who have features of PCOS but do not meet diagnostic criteria, an increased risk could be considered and reassessment advised at or before full reproductive maturity, that is 8 years post-menarche. So one should wait till it is 8 years post-menarche where this is concerned.
So the highlight is that when we are taking a history, we need to know when the menarche is. Because unless and until we've known how many years, we cannot be putting in this definition over there.
Yes.
And definitely for the ultrasound also, I'm sure you're going to be talking that the ultrasound also says.
So what are the challenges in diagnosis of adolescent PCOS? The dilemma in diagnosis of PCOS in adolescents, because normal pubertal symptoms like irregular cycles, acne, seborrhea, weight gain, increased hair growth overlap with PCOS symptoms. In adolescents, both menstrual irregularity and hyperandrogenism are required for diagnosis. Ultrasound is not recommended in these patients. Additionally, the time from menarche to full maturation of the reproductive axis can be variable post-menarche, which may bridge young adulthood. Megha had pointed out as to how to rule out Cushing syndrome and everything. AMH is physiologically high in adolescents, so that cannot be interpreted as PCOS as a diagnosis. The AMH cannot be taken here as an index in the marker. So PCOS in adolescents may be earliest manifestation of metabolic syndrome. It may later evolve or be associated with obesity, GDM, hypertension, type 2 diabetes mellitus, dyslipidemia, CAD, or endometrial hyperplasia and malignancy in later life. The common pitfalls are labeling an adolescent too early and yet failure to identify a child who has multiple risk factors. So the Rotterdam criteria, I will not repeat here because it's already been highlighted in the first lecture by Madam, and also Megha has spoken about it. So we come to this conclusion that Rotterdam criteria remains the gold standard for diagnosis, but for this special age group, adolescents, one must look at as to 1 year. When did they start their menarche? What should be the definition? Because they will present with menstrual irregularities, but that should be evaluated with a pinch of salt. That 8 years post menarche, one should wait and note down the age and then label them as PCOS, but yet not missing. An ultrasound does not feature into their diagnosis, nor does the investigation of AMH. So as the discussion was, the thyroid level should be evaluated, the other investigations to be done, the thyroid profile, the serum prolactin, and the blood sugars, and the other routine.
Dr. Jyoti, there's been some Dr. Neeti had reshared, so you'll have to restart the sharing.
Okay. Reshare. Reshare. Sorry.
It's not yours. Someone else went on. So
sorry, I'm sorry. Evaluation of a PCOS patient. Clinical assessment, detailed menstrual history, hirsutism using pheromone-Galway score, acne, acanthosis nigricans, clitoromegaly, alopecia, USG pelvis, polycystic ovaries, endometrial thickness on day 2. So this is not for the adolescent group. This is for generalized PCOS patient, but the adolescent should be separated from this evaluation. One cannot mix the routine standard investigation that we apply to everybody to this particular age group. That is why that question was put up. So coming to the next question, Dr. Poonam ma'am, could you take it up? We'll just share the slide from here. Second question.
I think this we have.
How to manage.
This we have already.
Yeah, this we've already discussed.
Okay, Dr. Seema, will you highlight how to manage PCOS in adolescent? Just once again, about the dosage of Dr. Shivani had said we have to give myoinositol 3 grams. Do you agree? Some people say it should be given 4 grams per day.
Basically, we give a combination of myoinositol and D-Cairo, and that should be into 40:1 ratio. And in a young adult, definitely this is my first choice when it is confirmed that it is PCOS cases. And they give very good result. And adolescent PCOS, first thing is lifestyle management, and second is this myoinositol and D-Cairo combination. And,
okay, so what is the role of lifestyle modification?
Lifestyle modification is excellent because this is a really favorite part of me, because I always speak a lot about this diet control, exercises, and physical. Like they have to calculate. Basically, they have to sit with the dietitian properly, and they should make their proper timetable, because this is timing of food and amount and proportion of food is very important. What they are having, it is very important because they are in a young age. They have to have certain cheat days also. So they have to include everything. The basic is to reduce the calorie intake and to take a proper proportion of protein and carbohydrate and fat. And secondly, they have to replace their carbohydrate diet to the refined. They should avoid refined carbohydrate, but they take a complex ones like multigrain attas and all. And the best part is that nowadays we are focusing more on the soya beans and this rajma and all. They are also very good as a PCOS diet. So they have to sit with the dietitian and calculate their diet, and they have to stick to that.
Soya has more of estrogen as far as I remember.
But for PCOS, they are giving as an alternative medicine. They are using it.
I have my doubts, ma'am, on this because soya is more of natural estrogen.
I actually read this in Dr. Nana Patel's book, and there's a separate chapter on what sort of Indian thing which we can have. So I was also surprised, but I really like that is
because soya.
I was also thinking this is phytoestrogen.
Yes, it is phytoestrogen. Natural only source of estrogen is advised post hysterectomy, oophorectomy at younger ages because there's no other way out.
I'll share that article also because I was reading.
We will have this discussion later on because anyway we'll sort this out.
Basically, they have to reduce their calories.
Doctor, what about people who do not use myoinositol and carousel like me? I don't use it. Any alternative anybody wants to say?
Madam, I would like to add over here is about using the oral contraceptive pills. She's 16 years. That doesn't mean we can't give her a COC. She's got acne. She's got probably maybe other signs of hyperandrogenism. And at present, there's no contraindication to giving to them. The only thing we bothered about is the height. But by the time they have had a menstruation,
the slide here on the adolescent
maximum height that can grow is only about 2 centimeters. Now, the amount of estradiol that you're giving should preferably be 20 micrograms. It should not be higher. If they're well controlled on 20, it's well and good. As far as the progesterone, we can use any of the progesterones. All the progesterones are good. It's not specifically that you need to give a drospirenol or ceftriaxone acetate. But yes, they have a more anti-androgenic effect over there. But all the COCs are good. And we should not say that we cannot give it to an adolescent, because now the data for DUB also and for PCOS says that you can easily give these to these patients.
But what
Do you agree to that
if
5 years should
DUB?
pass before you start OCPs from menarche?
No, I didn't get that.
5 years after menarche you start OCPs. Do you agree to that statement?
No, I don't.
It is not acceptable, doctor. और जब तक कोई guidelines में नहीं आया ना, तो ये मायोनेस्ट्रॉल वगैरह कहीं guidelines में नहीं आया, doctor. So I think guidelines के आप कैसे पढ़ा सकते हो ये?
Dr. Jyoti, what would you do to such an adolescent who comes with AUB? She's continuously bleeding. You've given progesterone, she doesn't stop. What would be the choice of drug?
The question is this: whenever these adolescents are bleeding, it is not because just of the progesterone. It is mainly because the endometrium is very thin, and they require estrogen at that particular moment.
Yes,
So if we add estrogen to them, they will stop bleeding. So that is why we say that at present, what are we bothered? It's only the height. Once menarche has taken place and the height that's left is only about 2 centimeters, patient has gained the maximum height already. So that is the only reason we all have this myth
The epiphysis closure is done by them.
So if they need it 1 year, 2 years post-menarche, we can easily add, and I think estrogen is better than progesterone for controlling the bleeding.
Yes. Any experience with Aquaviron, which used to be the choice earlier, the testosterone injection that was available?
Madam Wilson.
Now we are not giving.
Yes, now we are not giving, but earlier that was also being
Let me be very frank with you. When a patient comes to us, it is not uncommon, even in 2022, that the patient is continuously bleeding for 6 months, 8 months. Now, there we definitely use a short of hemostatic dose of Aquaviron. And people like me, when I was had just done a post-graduation, we used to say that only progesterone should be used. But now it has been reviewed time and again that the OCP is much, much better. And if you do an initial dose and, testosterone is not to be given for a long time, Aquaviron. But I think it works wonders. One has to use it. And my request with a folded hand is, whatever is not come in the guidelines should never come on the panel discussion.
Yes. We were going to lifestyle modifications for generalized PCOS. Dr. Seema was talking about it. Ma'am, could you continue?
One is diet, second is by exercises, because ma'am and Megha has definitely elaborated that role of exercises is there. Even if the patient is lean, the 7% weight reduction really matters a lot. Today only we saw a patient because not responding to any other drug. If their weight loss is there, even 2-3 kg weight loss they do wonders. So PCOS has a very big weight reduction, gives us a very good this thing. So weight reduction by any means, sometimes they supplement with weight reducing orlistat and etc. also, but we don't recommend normally. But by diet control, exercise and walk, the weight control should be there. And bariatric surgery definitely nowadays people are really promoting that. And if their BMI is too high, the bariatric surgery is also very good. Only thing they have to just delay their reproductive. This thing is almost more than 1 year to 2 years, so that they should be normalized. Minimum like exercises, definitely 45 to 50 minutes of exercise every day, or you can say if they can't do it, at least 3 times a week is also good. Basically, this is the thing. Lifestyle and yoga and meditation, that definitely work.
Any comment on intermittent fasting?
Intermittent fasting, if really, I feel it is very good to control the weight. It definitely brings down your metabolism and really brings down your BMI is also controlled with this. Intermittent fasting, I don't know much about it because I heard ma'am only when ma'am was speaking.
Madam, it reverses PCOD altogether. बस खाली click होना चाहिए.
But I have seen, ma'am, patients don't stick to it because there is no immediate weight reduction. After 1 month or so, सब जवाब दे जाती है उनकी हिम्मत intermittent fasting में.
Doctor, you should meet my dietitian. She has got put up this thing that 100 people she has given a good significant weight loss. I think they have to go to a dedicated person who does the weight loss. So I think that probably works.
So it should be a smart one, specific, measurable, achievable, relevant, and time limited. So bouts of 10 minutes progressively increasing by 5% weekly. We should give them realistic goals and achievable goals so that they are motivated and they do not lose interest in coming back for the treatment, especially when it comes to infertility. For that segment. Coming to the next question, how to manage and evaluate, Dr. Jyoti, this will be for you. How to manage, evaluate people who comes with a history of 3 years of marriage. Age of the wife is 28 years, husband age is 35 years, unable to conceive, tubes are patent, normal semen analysis, but she has an AMH of 10 nanograms per ml.
Yeah, thank you so much. Thank you, Dr. Jyoti, for that question. And I think seeing the AMH, she should be a PCOS, though we don't know about her. It has not been mentioned about her weight and her BMI and all.
She's a normal BMI patient. Let's assume she's a normal BMI patient and nothing is wrong with her except that her AMH was 10 nanogram per ml. And on ultrasound, she has PCOS.
Yeah, so we go ahead, we do her ultrasound, we see the AFC, and then whether the AFC
50 to 20 each side.
Okay, so she is sort of not a lean PCOS, but she's not a obese PCOS. That
yes.
So we are dealing with a case of PCOS here because the AMH is high. We have a good follicle count is more than 15, 16 per ovary.
15 to 20.
Here, my only thing is the tubes are okay. The husband semen analysis is fine. We go ahead with her basic other investigations, do her PSH and other baseline investigations, do her prolactin as well. So the cycles also may be regular, or are they irregular, Dr. Jyoti?
Cycles are irregular cycles.
Okay, if cycles are irregular, definitely we also go ahead with the serum prolactin levels. Yeah. And then we start seeing, we also ask how the cohabitation has been. I mean, they have been married for 3 years.
Everything is normal. There is no significant history or thyroid prolactin. Everything is normal. My question is fertility management in this patient. What would be your take on it?
Yeah, so we start going ahead with the ovulation induction. And if the FSH-LH ratio, if the LH is high, then maybe I would like to give her a OCPs for a month or so before starting ovulation induction. But if it is ratio is not much altered, and as also the evidence states these days that we go ahead as letrozole has, aromatase inhibitors have come up as the first line of ovulation induction in PCOS cases. Though we may start, can also give clomiphene, but it would be, it is actually subjective to whether she has been given ovulation induction in the past and what all has been used on her.
Nothing.
Okay, so if she is coming for the first time and seeing the follicle count, I would like to start her with letrozole 2.5 mg BD for 5 days. It can be started from day 2 to day 5 or whatever, day 3 to day 7 for 5 days, and do the follicular monitoring, and then we go ahead with the IUI. I would advise a IUI for her, and or in fact 1 or 2 cycles of timed intercourse is also not a bad option for this, because this is the first time actually we are putting her for all this treatment.
Yes.
Now if she has been, if 1 or 2 cycle goes like that with the timed intercourse with proper ovulation induction, we have documented that there is ovulation, there is after the follicular monitoring, and still she is not able to conceive, then I would advise a IUI for her. Now 3 to 4 cycles of IUI is the max that should be advised. And if we have used clomiphene and she has there is a clomiphene failure, then the second line can be letrozole if we have started with clomiphene in this case.
Don't you think letrozole should be the first line in such a...
I would use letrozole as the first line of treatment for her. Since the guideline these days, letrozole has become the first line of ovulation.
Monofollicular growth is what you would expect with such a PCO patient.
Absolutely. So because
now let us say she failed with it, then what would you do next?
Right. So we add on gonadotropins if we are not straight away.
You need to define, Dr. Jyoti Bali, you need to define what does failure mean. Did she not respond or did she
She did not respond to anything?
Yeah. So it was a failure of the oral ovulation. So we add. So now should we? Are you pushing her to IVF?
I did not say anything. You're putting words in my mouth.
All right.
There are no answers to this question.
Yeah. So now is the time to start adding. Already, I would start adding metformin right from the time she's come along with, because already in these cases it is always a good option after doing all this counseling and things like that, to add all these metformin, minoxidil, whatever the options that we have got, because obviously they are going to reduce the insulin resistance. They are going to also prevent hyperstimulation as such when we are going to do ovulation induction with gonadotropins in these cases. So metformin is one thing that we can start
how
right
long
away.
do you wait after adding metformin, and what would be the criteria?
2 to 3 months. 2 to 3 months of adding metformin, and then we can put in her for the IVF stimulation in that case. Once if the IUIs have failed, since we were trying IUI for 3 cycles.
Before going for IVF, is there any role of laparoscopic drilling? I would ask everybody. Dr. Jyoti first.
No, I don't think for laparoscopic drilling, no.
See, lap ovarian drilling is basically for patients who are lean PCOS, or in case we are taking her for laparoscopy since she has only undergone HSG. Now, since we have failed 3 cycles and she has ovulated, maybe then that is the time when we are taking her for diagnostic laparoscopy. We can take a consent for ovarian drilling at that very particular sitting if we are going ahead with the laparoscopy. Not only
has an opinion on this. Anybody else who would add regarding laparoscopic drilling? Sharda Jain ma'am, Dr. Jyoti.
If the patient cannot afford gonadotropins, if the patient is far off, if she doesn't want IVF, if she cannot, then only these, or if she is a lean PCOS, these are the only options where we can go in for LOD.
Poonam ma'am, would you add something to this?
Dr. Normally, if image cutoff is more than 5, sometimes we see more than 10, then definitely we go for ovarian drilling. Because that gives prevent the hyperfiltration also, which is risk also. Whenever you are taking the patient for...
Megha, any opinion on that?
I would just prefer lean PCOS patients, or they are not ovulating or not responding to the drugs. Then, specifically, if they cannot go into IVF, then I would go for ovarian drilling, not in all such.
So my criteria, if Jyoti, I can just add. I'm not in favor of ovarian drilling at all. And I think the patients who would merit are the ones who stay very far off, who cannot come for an IVF, and who would probably not come back to me. Only in these
where a laparoscopy is justified, there you would do it. Combine it and do it as a...
Otherwise, if I have the facility for an IVF, then I would use straight away an IVF.
I think we're all on the same page on this. So, Jyoti, now you have taken it up for IVF. What will be the choice of protocol for IVF, Dr. Jyoti?
Yeah, so in these cases, definitely we are fearing hyperstimulation and we want to avoid multiple pregnancy. So these are the 2 things that we have to take care of in cases of PCO patients. So here we would like to go, we would be using low dose gonadotropins and antagonist protocol.
Okay. And what is the dose you would be using here in drug of choice?
The maximum I would be using is 150.
Okay.
150 and accordingly I would do follicular monitoring. Maybe after 5 days review her. Then maybe gradually step up. And maximum dose that I would go in her is 225. So
and recombinant FSH.
And recombinant. And then accordingly, it would be an ANTAG protocol. So there are it could be a flexible ANTAG. Once
Last
it
2 or 3
reaches,
days of stimulation, would you add a little LH to her?
no, if we are using only recombinant, then definitely we would like to add a little. We would like to add HMG, maybe from the 8-9 day onwards. Adding a HMG means indirectly adding the LH.
And choice of trigger?
And trigger would be agonist trigger, blind agonist trigger, nothing else.
Okay. And
so once we have done that, and in case, depending on the number of oocytes that we've got, but most probably we should be going in for a freeze-all in most of these cases.
yes.
Freeze-all and segmentation of the cycle and doing an embryo transfer in the natural cycle.
Yes. Even if you have taken up agonist trigger, what would be your prescription post-ovum pickup for this patient?
Yeah, post-ovum pickup actually also sometimes, in fact, dopamine agonist, these cabergoline is something we start right from the day of the pickup. And also ask her to have lots of fluids, lots of liquids, and to report if she complains of any bloating or any pain abdomen, or if also have lots of almonds also, because that prevents all this hyperstimulation. Though there is a little risk, whatever we have used, still there will be a little free fluid in the pelvis.
And I would like to give her an ANTAG also. And this
Okay. So you would like to continue with ANTAG for another 5 to 7 days after the pickup?
Yes.
And no intercourse.
Starch, and maybe give her starch on the day of pickup itself. Then while she's admitted with you for 4 to 6 hours, you can even give her 6% ethyl starch.
Yes,
so that
agreed.
And high protein diet is what I advise. Capgolin, if you think it can be added, you please add it for your safety purpose. If she's traveling or she's a far off person or she's a donor cycle, in that case, Capgolin can also be added.
For stimulation, we use combination of HMG and FSH recombinant.
Yes. And the last question, Dr. Poonam ma'am will take it up. It goes to Dr. Jyoti Bhaskar ma'am.
Dr. Jyoti, what is the role of adjuvants in PCOS? And what is your experience if you use any of that?
Okay, so what are the adjuvants and what are how do you use them and justify their usage?
So as far as the adjuvants that I use in my clinical practice, the list we all see is over there. And as Dr. Jain said, that we have to be very clear whether evidence does support the use of these adjuvants. They're present in the market, but we should be sure why we're giving it and to whom we need to give it. The one that I use is metformin. And metformin, I have certain specific indications for which I use metformin. That is, they're not responding to my ovulation induction drugs. Second is that the BMI is very high, that in Indian standards it may be considered 25, more than that, or 30 by the Western standards. And the third is the OGTT is found to be deranged. Only in these 3 particular conditions that I give metformin. And yes, another indication of metformin, as we've been discussing, is to prevent an OHSS if you're getting an over response. That's the one. The other one that I use is a vitamin D. That is the one that because these all patients have been found to have low vitamin D, and somewhere the vitamin D is one drug which affects every other aspect is concerned. Now, as far as use of the steroids are concerned or the glucocorticoids are concerned, if the patient has got severe hyperandrogenism but is not diabetic, then they are using it. But I personally do not use this particular drug. Rest of them, myoinositol, NAC is concerned, or we are causing of the chromium polynicotinate, all of them are known to decrease the insulin resistance. But as far as what the evidence in favor of them, whether they are to be prescribed, it's a matter of choice. Evidence does not show that they are, by any of the guidelines, recommended to be utilized. Melatonin.
What about melatonin?
Yeah, as far as the melatonin is concerned, melatonin is, I would say, I don't know how much role it has in PCOD per se, but yes, it is known to be given, synthesized by the pineal gland, and then it tends to go from the blood into the ovarian follicle as well as the granulocytes, but definitely has a very good role in the poor responders. That is where when the AMH is found to be low, melatonin has an important role, but as far as PCOD is concerned, I'm not too clear. Anyone else can put the highlight on that. So I only use metformin when indicated by the patients, but rest of them, I'm not fond of it.
Ma'am, side effects of metformin.
Yeah, metformin, one has to be very careful when tends to give it. Cannot be just given offhand. You need to start that very slowly with 500 milligram once a day for a week, and slowly tend to step it up. Metformin is known to have a lot of gastrointestinal side effects, and we have seen some patients who landed up with a liver failure when we have been giving them much higher dose, severe hypoglycemias. So this is not a drug that we just need to give it off as chocolates. They have to be given only when indicated, and they need to be well guarded when we're giving these drugs to them. Yes, Jyoti, back to you.
I think fairly you have explained about all the adjuvants. I don't think we need to use much of the adjuvants because the cost is very high. Instead of moving on to adjuvants, I think lifestyle intervention it has more importance. If we stress on that, and if the patient pays to dietitian, I think that is more effective than the spending upon adjuvants.
Vitamin D does have a great role.
Vitamin D, metformin, those
controls
I agree.
Insulin levels and also in regular cycles, ovulation, it affects everything.
Poonam,
Have your final comments?
The lifelong management would see the consensus guidelines from Endocrine Society 2010. All PCOS women be assessed for cardiovascular disease risk, BP, waist circumference, BMI at every visit, complete lipid profile, reassess every 2 years or sooner if weight gain, and then 75 OGTT has been already discussed. Reassess every 2 years or sooner if new risk factors. And A1C has promised assessment of depression, anxiety, and emotional quotient, of course, needs to be taken into consideration.
So one thing I need to ask the moderators, we were talking about insulin, fasting insulin in 2 hours. What is the recommendation as far as doing the insulin levels?
They say that the GTT levels should be done before, starting metformin. That's what, you can't start it to every PCOS.
No, I'm not talking about that. GTT we all know, but what about fasting insulin and PP insulin? Is that a routine recommendation?
10 fasting. Fasting is more than 10. That is the what criteria. If I ever get it done, I use that criteria.
Dr. Jyoti, now they are not used anymore.
No, we don't use insulin.
They're not used anymore.
Yeah. So that's what I think. Insulin is not in any of the guidelines to be used as a modality for insulin.
और मेरे जैसे लोग कहेंगे मेटफॉर्मिन से डरने की जरूरत नहीं है डॉक्टर साहब, लिवर फंक्शन तो वैसे ही कराते हैं हम लोग, मेटफॉर्मिन से बिल्कुल डरने की जरूरत नहीं है. अगर आप मेटफॉर्मिन नहीं यूज करो और आईवीएफ कर दो तो आपका हाइपोस्टिमुलेशन के चांस रहेंगे, चाहे आपने एंटैक प्रोटोकॉल ही यूज किया.
Yes, certainly.
And they also did the PC guidelines that with the use of metformin, the progression of the PCOS symptoms is slowed down. So later on, the cardiovascular risk and the diabetes, hypertension, these also the risk factor decreases, especially in young females also. So I think
Madam, the crux is weight loss.
If weight loss after that, like what the add-ons are.
Yeah, if lifestyle modifications are not effective and the patient is despite good effort, then maybe.
So bringing to an end to PCOS, of course, it will be the beginning again after maybe 6 months or a year, because it is a never-ending topic where chicken came out, egg came out of chicken. The story remains here with PCOS. So saying a heartfelt thank you to all of you today who were a part of the panels. Our eminent speaker, Dr. Sharda Jain ma'am, my co-moderator and a senior faculty, Dr. Poonam, who is also in charge of the Infertility Committee. A heartfelt thank you to everyone present here. So meeting next 20th of June. Till then, enjoy the summers.
Thank you, ma'am.
Thank you.
Thank you, Dr. Jyoti and the whole team.
Thank you, Sharda Jain ma'am.
Thank you very much.
Dr. Shivani, a reminder again, next 20th will be you speaking on the topic that's been assigned.
What is next 20th topic? Dr. Jyoti?
Dr. Shivani would be taking it up.
Recent advances, Dr. Sir.
Recent advances.
You can add on something, Dr. Jyoti Malik.
ठीक है मैम, ठीक. Thank you, ma'am.
Welcome.